Liposarcoma stands as the most common malignant soft tissue tumor in adults, typically manifesting during the 5th to 7th decades of life as a painless, deep-seated mass within the retroperitoneum or the proximal lower extremities. The classification of these adipocytic neoplasms relies on distinct cytogenetic and molecular signatures that dictate their clinical behavior and prognosis. Well-differentiated liposarcoma, also known as atypical lipomatous tumor when located in the extremities, often harbors a characteristic amplification of the chromosome 12q13-15 region. This genetic aberration leads to the overexpression of the murine double-minute-2 gene, which functions as an oncogene, by binding to and degrading the p53 tumor suppressor protein through its ubiquitin ligase activity. On gross examination, these tumors resemble mature adipose tissue but show scattered atypical spindle cells and hyperchromatic nuclei within fibrous septa. Histologically, the presence of lipoblasts is a classic finding, representing immature adipocytes with eccentric indented nuclei and multiple clear cytoplasmic vacuoles containing lipid. Dedifferentiated liposarcoma frequently arises from a pre-existing well-differentiated lesion and exhibits a more aggressive clinical course marked by a non-lipogenic sarcomatous component and a higher risk of distant metastasis. Myxoid liposarcoma represents a separate entity characterized by a specific reciprocal translocation between chromosomes 12 and 16, producing the fusion protein known as fused-in sarcoma and cyclic adenosine monophosphate response element binding protein 3, like 2. This fusion product acts as an aberrant transcription factor that interferes with normal adipocyte differentiation. Microscopically, myxoid liposarcoma displays a prominent plexiform chicken wire capillary pattern and a gelatinous myxoid stroma rich in non-sulfated glycosaminoglycans. Pleomorphic liposarcoma is the rarest and most aggressive variant, showing high-grade nuclear atypia and numerous bizarre mitoses without a specific recurring translocation. Diagnostic evaluation often involves magnetic resonance imaging, where liposarcoma shows variable signal intensity depending on the fat content and degree of cellularity. Management primarily involves surgical resection with wide margins, while radiation and chemotherapy may be utilized for high-grade or unresectable disease. Metastatic spread occurs hematogenously, with the lungs being the most frequent site of secondary involvement. Understanding these molecular pathways is vital for medical board examinations, as they highlight the intersection of genetics and oncology. One must distinguish liposarcoma from benign lipomas, which lack murine double-minute-2 amplification and atypia. Vigilance is required for retroperitoneal masses, as their size often leads to late-stage presentation.